Okay, let's just jump right in. I want to start today with a word that honestly just sounds intimidating. Cholesteatoma. It feels heavy, right? It sounds like the final boss in a medical textbook.
It really does.
You hear chol, ste, toma, and your brain immediately jumps to, cholesterol and tumor.
Exactly. It has that scary oma suffix we've all been taught to worry about.
Yeah, but here's the thing, and this is the first big twist in our deep dive today. That name is, well, it's basically a lie.
It's a complete misnomer.
Yeah.
Arguably, one of the biggest in otolaryngology. It has absolutely nothing to do with cholesterol, and it's not, strictly speaking, a tumor.
So what are we actually dealing with here?
Yeah.
Because the source material describes something that sounds almost mundane, but with these catastrophic consequences.
We are dealing with skin.
Skin.
Just skin. Specifically skin in the wrong place.
You mean like the skin that's on my arm right now?
Exactly that. The technical term is keratinizing squamous epithelium. Now, your ear canal is supposed to be lined with that. But behind the eardrum, in the middle ear space,
That's off limits.
that's sacred territory.
Yeah.
It should be lined with a moist mucous membrane like the inside of your nose. It should never have skin in it.
So a cholesteatoma is just skin cells that have crossed a border they weren't supposed to?
That is the fundamental definition. It's a cyst or a sac of skin that gets trapped in the middle ear.
And that sounds harmless. I mean, we shed skin all the time. It becomes dust.
Precisely. But that's the problem. On your arm, it just flakes off. But inside a tiny bony box like your middle ear, it has nowhere to go.
So it just builds up.
It builds up. The dead skin cells, the keratin, they get trapped and start layering on top of each other like an onion. And that benign-sounding ball of skin starts to act very, very maliciously.
Before we get into how it destroys things, what does it actually look like? The description in the notes was surprisingly aesthetic.
It is, which is so ironic. It's often described as a pearly white mass. Yes. It has an outer shell, the matrix, which is the living skin. And then the center is filled with all that white keratin debris. It literally looks like a small white pearl tucked away in the ear.
So you have this pearl that looks harmless, but it eats bone. I think my first guess, and the old theory, was just pressure, right? The bag gets too full and it crushes the walls.
That's a very logical assumption. That was the pressure necrosis theory for a long time. The idea that it grows, puts pressure on the blood vessels, and the bone dies.
Like a trash compactor,
Exactly. But researchers actually measured the pressure inside these sacs. It's usually under 25 millimeters of mercury.
which isn't enough.
It's not high enough to cut off blood flow.
Mhm.
So that theory has been, for the most part, debunked.
So if it's not a physical crushing, how is it destroying bone?
It's chemical warfare. This is the enzymatic theory.
Okay.
That skin sac triggers an immune response.
Mhm.
The body sees this foreign tissue and recruits osteoblasts, the cells specifically designed to break down bone and other inflammatory cells.
So the body is tricked into destroying itself.
Essentially, yes. These cells release this cocktail of enzymes, collagenase, acid phosphatase, and these chemicals literally just dissolve the bone.
Wow. So it's not a sledgehammer, it's acid.
That's a great way to put it. And there's usually a primary victim. One of the first bones to go is almost always the long process of the incus.
One of the little hearing bones. Why that one specifically?
It's an anatomical vulnerability.
Mhm.
It relies on a single, tiny blood vessel for its nutrients. There's no backup supply.
So it's incredibly fragile.
Very. The moment that enzymatic process starts, that vessel is compromised and the bone just melts away.
That is terrifyingly specific. Okay, so we know what it is and what it does, but how does the skin even get in there in the first place?
Right, this is the big mystery. And there's several theories. The source material gave a really great mnemonic to keep them straight. Real big ears make echoes.
Real big ears make echoes. I like it. Let's break that down. What's the R?
R stands for retraction pocket. This is probably the most common cause, and it starts with the eustachian tube.
The thing that makes your ears pop on a plane.
Exactly. If that tube isn't working right, maybe from allergies or a cold, the air in your middle ear gets absorbed, but no new air comes in. You end up with a vacuum.
And a vacuum sucks things in.
It sucks in the weakest wall, which is the eardrum. It pulls the drum inward, forming a little pocket, a little cave.
And the outer layer of the eardrum is skin. I see it now.
The skin gets pulled into that cave, the entrance can get pinched off, and now it's trapped. It can't clean itself. And that's the beginning of your pearl.
The ear literally inhales its own skin. Wow. Okay, so that's R for retraction. What's B for big?
B is for basal cell hyperplasia. This is Ruedi's theory. It's less about physics and more about biology just running amok.
How so?
The idea is that with a chronic infection, the inflammation stimulates the bottom layer of the skin, the basal layer, to just start growing like crazy. It forms these little cones of skin that invade downward into the middle ear.
So it's not pulled in, it actively invades.
It's much more aggressive, yes.
Yeah.
It breaks through and sets up shop where it shouldn't be.
Okay. R is retraction. B is hyperplasia. Ears. What's E?
E is epithelial migration. This one needs an open door.
A hole in the eardrum.
A perforation, exactly. Maybe from a childhood infection.
Mhm.
The skin from the ear canal sees this raw open edge and it just crawls right through the hole into the middle ear.
It just walks in.
It thinks it's healing a wound, which is what skin is programmed to do, but it's migrating into a place where it becomes a disease.
Unbelievable. Okay, so M for make.
M is for metaplasia. This was fascinating. It's like an identity crisis for the cells themselves.
What do you mean?
Think about a smoker's lungs, how the cells change to try and protect themselves. That's metaplasia. The theory here is that with chronic infection, the delicate lining of the middle ear says, I can't survive this, and it transforms itself into the tougher skin tissue.
So the skin isn't an invader, the ear creates it on its own.
Exactly. The local tissue just changes its identity and starts producing keratin.
And the last one, echoes.
Echoes is for embryonic cell rests. This is the congenital theory. This is the one you're born with.
You can be born with this.
You can. During development in the womb, sometimes little bits of skin-forming cells get trapped in the temporal bone where they don't belong. They're supposed to disappear, but they don't.
A little ticking time bomb.
Pretty much. And there are very strict rules to diagnose this, Levinson's criteria. You have to have a perfect intact eardrum with this white pearly mass visible behind it and absolutely no history of ear infections or surgery.
A pristine crime scene with a pearl in the middle.
That's the perfect description.
Okay, so one of these 5 things happens. I have a pearl growing. How do I know? What are the symptoms? I'm guessing pain.
You can have pain, but the absolute hallmark symptom is the smell.
The smell.
A foul-smelling ear discharge.
Yeah.
The medical term is otorrhea, but it's distinct.
What makes it smell so bad?
It's a combination of the bone literally rotting and a superinfection from bacteria like Pseudomonas and anaerobes who are having a feast on all that dead keratin.
That's vivid. So a smelly, draining ear is a huge red flag. But the notes mention something counterintuitive. A warning if the ear suddenly stops draining.
Ah, yes. The dangerous stop. If you have a chronically draining ear and it suddenly goes dry, you might feel relieved.
Yeah, I think it's getting better.
But it's usually an ominous sign. It means the exit is now blocked, maybe by a crust or a polyp. The infection is trapped. It's a sealed pressure cooker, and the destruction can accelerate dramatically.
So a dry ear can be a bad sign. Got it. Now, there was a phrase in here I just can't get out of my head. The cholesteatoma hearer.
Yes. This is one of the great paradoxes of this disease.
It sounds like a character in a fantasy novel.
It really does. So normally when the disease eats through your hearing bones, your hearing should plummet. The connection is broken.
Makes sense.
But sometimes a patient has a huge cholesteatoma that has completely destroyed a bone, yet their hearing is surprisingly okay.
How is that possible?
The mass itself, the cholesteatoma sac, fills the gap left by the eroded bone. It physically bridges the space between the remaining bones.
No way.
So the sound vibration travels through the disease. The cyst itself acts as a crude prosthetic.
So the disease is literally doing the job of the part it destroyed. That is wild.
And it's so dangerous because the patient thinks they're fine, they can still hear, but the whole time the destruction is spreading.
And when you do surgery to take it out?
Their hearing gets worse.
Yeah.
We have to remove that bridge. It's a very difficult conversation to have. We have to make your hearing worse to make your ears safe.
What a terrible choice. Does this show up differently in kids?
It does, and unfortunately it's often more aggressive.
Why is that?
It's about anatomy. Kids' temporal bones are more pneumatized, meaning they're like a honeycomb full of little air cells.
So there's more space for it to spread.
It's like an open highway. In an adult, chronic infection can make the bone hard and dense, which slows it down.
Yeah.
But in a kid, it can just spread everywhere, very quickly.
Any good news for kids?
A little. For some reason, even with more widespread disease, they are statistically less likely to get facial nerve damage from it compared to adults. Their nerves seem a bit more resilient.
Okay, let's talk treatment. This sounds like something that needs to come out. There's no pill for this, right?
No, zero. This is surgical disease, period. Conservative management, which is just regular cleaning, is really only for very elderly or frail patients who can't tolerate surgery.
And what are the goals of that surgery?
2 goals, in a very specific order. Number 1, make the ear safe. Remove all the disease. Number 2, try to restore hearing. Safety first, always.
Right. You can't live with a brain abscess.
Precisely. And that leads to the big surgical debate. Canal wall up versus canal wall down.
That sounds like a home renovation show.
It's the perfect analogy. Canal wall down is the open concept approach. You drill away the bony wall between the ear canal and the mastoid bone behind it, creating one big cavity.
And the benefit of that is?
Visibility. No hidden corners. Makes it very easy to monitor for recurrence. The disease has nowhere to hide.
But the downside must be you have a giant cave in your head.
You do. It changes the anatomy. You often need to keep it dry for life, so no swimming without plugs. It can be a commitment.
So what's the other option? Canal wall up,
That's where you leave that wall intact. You preserve the normal anatomy, you work around it.
which sounds much better for the patient.
In the long run, yes.
Yep.
But it's technically harder, and there's a higher risk of leaving a tiny bit of disease behind in a blind spot.
And if you leave even one cell.
It will grow back, which is why those patients need long-term follow-up, usually with imaging like a CT scan.
Right. The notes mentioned looking for a blunted scutum.
Exactly. The scutum is a sharp little spur of bone. On a CT scan, it should look like a sharp point. When a cholesteatoma starts eroding it, that point gets worn down or blunted. It's an early warning sign.
So we've gone from a scary name to a skin pearl, chemical warfare, and now open concept ear surgery.
It really is a journey. It highlights just how complex that tiny space in our skull is.
So what's the big takeaway for us? For me, it seems to be that in biology, it's all about location, location, location.
That's it, exactly. Skin is a wonderful protective organ on your arm. It's a benign thing that becomes malignant in its behavior simply by being in the wrong place.
And it really drives home that you shouldn't ignore chronic ear symptoms. A smelly, draining ear is not just an annoyance.
It's a sign that a serious biological process is happening. You need to get it checked.
The thing I can't stop thinking about, though, as the final thought to leave everyone with, is that idea of the cholesteatoma hearer.
It is the most striking concept, isn't it?
It's this idea that the body is so desperate to maintain function that it will literally use the disease to do the job. It creates a facade of function.
It's an incredible, if misguided, adaptation. It's masking the underlying failure until it's almost too late.
It just makes you wonder, what other parts of our lives, medical or otherwise, are like that, where things seem to be working just fine on the surface, but only because the problem itself is hiding the decay, propping up the structure that it's simultaneously destroying.
That is a very provocative thought. That function can sometimes be the ultimate disguise for a collapse that's already well underway.
Something to think about. Thanks so much for taking us through this.
My pleasure.
And to everyone listening, check your ears. We'll see you on the next deep dive.